Up. It's 2 minutes after the hour. Good afternoon, everyone. Thank you for joining us at Geriatric Medicine Citywide Grand Rounds for the University of Toronto. It's been a little while since we last met in November, interrupted by the Omicron wave, and I hope everyone is doing well and welcome you back to these bi-monthly events. Before we start and before I introduce our guest speaker, I do want to do a land acknowledgement. The land on which we work, study, and live is recognized by many Indigenous nations who have long-standing relationships with the land on which the University of Toronto Department of Medicine is located. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. More concrete acts of restitution and transformation are needed to address underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. Today's grand rounds are being delivered by Dr. Paul O. Paul and I go way back to our residency days and our subspecialty training days in clinical pharmacology. And Dr. O is the medical director and Good Life Fitness Chair of Cardiovascular Disease Prevention and Rehabilitation Program at the University Health Network, Toronto Rehab, and Peter Munk Cardiac Center. He is Associate Professor of Medicine at the University of Toronto, and he has participated in many national guideline committees and has had several leadership roles in provincial and national advisory committees around heart health and policy. He has authored over 300 peer-reviewed publications and is principal investigator on a number of grants examining exercise, behavioral, and educational interventions for the primary and secondary prevention and management of cardiovascular conditions, diabetes, and other chronic disease. And just about everything that's good in life is improved with exercise, including for all age groups. And that's why Dr. O is here to talk to us today about the importance of physical activity and exercise in older adults. Thanks for joining us, Paul, and over to you.
Barb, thanks very much for the nice introduction. And it's wonderful to be with all of you again. Here are some disclosures just to get me going for the formalities that in the last year that I've served on a couple of advisory boards, one with Biogen, another engagement with Novartis. That as my chair title indicates that I do hold some research funding through Good Life Fitness. They provide a gift through our hospital foundation that then provides funding for my research chair. And I do have some ongoing projects with Apple around health technology and physical activity. I don't think that these relationships will influence our content of our session for today. Here are the objectives as they were circulated to you, that in the next 45 minutes or so that we're going to go through a review of the declines in fitness with age and just what happens as we get older, what's happening right now as we're sitting in on this session. And the reason that that's important is that there is a relationship between poor fitness and losing independence, developing frailty, and developing chronic diseases. So that's on the downside. On the upside, that there is hope, and that regular activity, exercise, movement, the construct of all of these things on a continuum does actually comprise one of the best medicine interventions that we can offer, as Dr. Liu has indicated. And I want to illustrate some of this with kind of case examples from my world of cardiovascular rehabilitation. Um, on that note, this is the sandbox that I've been in for the last 20 years or so. As Barb said, we did clinical pharmacology and some of our internal medicine training together. I did GIM at Sunnybrook for about a dozen years and then shifted over to outpatient cardiovascular rehab. And now in our programs, we see about 2,000 people per year at both the Toronto Western and Toronto Rehab sites. We develop and implement structured programs that go from 4 to 6 months that deal with physical activity, exercise, movement, not being sedentary, as well as many other health behavioral interventions. We have weekly contact with our clients, and we also do assessments and testing. And these photos, you could say, are very apropos for the COVID world because there's no patients in them at all, which is really sad. We are, like you, welcoming more people on site again. Actually, we have been throughout the pandemic, but in better times, all of these photos would have been teeming with active individuals. So here is kind of the backgrounder about why this is an important topic. And these are things that are sort of motherhood, fatherhood, parenthood to all of you, that they're, I'm sure, very, very familiar, that we know that a normal aging process is associated with declines in cardiorespiratory function and measures of fitness like VO2 peak, your maximum oxygen carrying capacities. We lose muscle mass. And as a result, we lose strength, we lose flexibility. And the culmination of all of these things is that many people that we work with, they're around us, that we are connected to, may lose their independence over time. And of course, I don't need to expound on this area for you learned individuals on this call in geriatrics. That close construct of fitness and strength connecting through to function and independence has been well established in many, many physiologic clinical studies. So we should go back to this and think about how do we defend fitness and strength, because we're fighting time, we're fighting the clock. And if we look at data, and these are data from our own program in a cardiovascular cohort, we analyzed data from a number of years and just simply plotted peak fitness levels that are measured in milligrams or milliliters per kilogram per minute of oxygen consumption at peak of exercise activity. Versus age. And you can see there is a lovely linear relationship. Unfortunately, it goes in the wrong direction, wherein people will have a reasonable level of fitness when they're younger, in their 40s and 50s, but then this declines progressively. And when we get into our 70s or 80s, the numbers actually become rather alarming. The blue line in the middle denotes a VO2 of 15 mils per kilo per minute. And I'm sure many of you would recognize that's an important sort of threshold number, because that level of physical fitness, functional ability denotes the separation between being rather independent versus being dependent on the lower hand side. It denotes other bad things happening in the cardiovascular world. One of them as a marker that we could think about is if your VO2 at peak is below 15 and you're living with heart failure, then that is one of several criteria that might qualify one for a heart transplant. Whereas if you're above that, you're deemed to be doing okay from a functional perspective. So think about that. This is kind of like the edge of a cliff phenomenon, that fitness as it declines over age takes us close or over the cliff. These are baseline data. We can do something about this. Compound this with this inexorable loss of muscle as well with age. And you can see, gosh, everything goes down past the age of 40, which is rather shocking and alarming. And as I get closer to 60, I'm thinking, oh boy, this is going to be a fun couple of decades coming up. So we lose fitness, we lose muscle with age, and loss of muscle mass also, of course, contributes to many systems, including losses of cardiovascular fitness and function, as well as metabolic derangements and alterations in our abilities to do many of the important things in life. So it shouldn't be surprising that there is a relationship amongst these sorts of parameters with what happens to people over the long term. This is a study that's a little bit older, but I like it because it's Canadian in nature. It comes from London, Ontario. It looked at about 440 individuals who were living healthily in the community. They had a mean age of 67. They were followed up over several years, and the observation was that about 1 out of 7 of these folks became dependent, as noted in the pie chart below, that some needed a walking aid, some needed home health care, and some actually needed a transfer of residence into a nursing home or long-term care facility. When the authors examined the variables or the factors that influenced dependence, to no one's surprise, getting older by itself was a strong predictor of becoming dependent. Having a number of comorbidities was also a driver of becoming dependent. And of course, almost everybody has some sort of comorbidity. And then the other really important one was VO2 peak, that's shown in the red text, that having a higher VO2 was protective against becoming dependent. And of course, the answer, the rhetorical one that I'll ask is, of these candidate variables, which of them is modifiable? And of course, it is around the fitness equation. So let's park that as something that we can look to for intervention down the road. Dissecting and diving further into the fitness and dependence relationship, you could see again, I'm going to show you lots of curves or lots of bar charts that just go from top left to bottom right, unfortunately. This one is actually, though, a positive kind of relationship that says, once again, that when our VO2s are the lowest, that the ratio, the risk, in this case, the odds ratio for dependence is the highest. And as VO2 goes up, we get to be protective. And one can actually develop a relationship here. And it's interesting, in the literature, we think that 1 milliliter per kilogram per minute of VO2 is actually quite a powerful predictor of many things. 1 mil per kilo per minute denotes a 10% difference in cardiovascular mortality, for instance, in large cohorts. And in this case, for this conversation, this same sort of clinically important difference in fitness denotes a 14% risk of dependence over time. So defend your fitness, defend your independence would be the call out. And societies, large societies in medicine, have recognized the sentinel importance of things like fitness. And for the first time, in its long history, big agencies like the American Heart Association and the Cardiovascular Societies in the States published a statement like this, emphasizing the importance of cardiorespiratory fitness. In fact, the authors of this particular guidance were calling out that fitness should be on the same plane as heart rate and blood pressure as a vital sign. Once again, pointing to a bar chart that shows a significant relationship between fitness, shown in these tertiles, versus, in this case, total mortality. Low fitness has a high mortality rate, high fitness, a low mortality rate. So for many reasons, we should be looking at fitness, assessing fitness, and then doing something about it, which will be the next part of our conversations. With a more age-specific kind of look at the relationship, this was a broad, larger population-based analysis of women in Australia. Often, of course, we are lacking in data about women in particular, so we like to call it out when it exists. In this publication and analysis, a number of risk factors for cardiovascular disease were examined, including in red, smoking, blue, physical inactivity, green, high BMI, and in orange, high blood pressure. And for those of you who work closely in the cardiovascular field, you might have predicted, well, you know, the traditional risk factors like high blood pressure are probably the most important thing for occurrence of cardiovascular events like stroke and heart attack. So it's interesting when one stacks that up on a population attributable risk, that certainly blood pressure is important as a cardiovascular risk. But when one thinks of what is common in the population and what has impact, then some of these, quote, lifestyle factors actually become much more important. And for the very young, you know, smoking might actually be the most important thing for a 20-year-old in terms of predicting cardiovascular risk. But as we get up above the age of 30, no surprise, because I put these slides together, that physical activity, in fact, becomes the dominant population attributable risk factor, because it is so common to be physically inactive and it is so important, tied to cardiovascular risk, total risk, or dependence. And of course, those constructs are rather tied together, but you can see here in our oldest age group that physical inactivity is incredibly important. And I would argue, of course, that this is modifiable for many individuals as well. So why is the population attributable risk so important? Well, when one looks at Canadian data, for instance, around physical activity patterns, this is percent of the population who are meeting physical activity guidelines. And roughly at the time of this survey, this was the familiar, how many individuals are getting 150 minutes of moderate to vigorous physical activity per week. And for the entire Canadian population, that's like 22% or so. Younger people tend to be more active than older individuals. And when it comes to our older individuals, the average percentage here was around 12 or 13% actually meeting physical activity guidelines. The converse of that, of course, is that it's like 80 to 90% or even more who are inactive by these threshold definitions. You know, if I'm a glass half full optimist kind of guy and I'm running a clinic, I'll say, hey, this is great, because it means that every person that I will see in my clinic today deserves a conversation about physical activity, because it's relevant for every single person. And this is what's behind population attributable risk, of course. It's common in the cohort, it has impact, therefore it deserves an intervention, it should be elevated, it should be a vital sign that we look at. 88% of seniors don't get enough. The converse, of course, or the construct of not getting enough physical activity, of course, is that we spend a lot of time being sedentary. And you would have predicted, of course, that this is absolutely true. Gosh, it's true for most Canadians. But in terms of the senior population from these same kind of Canadian health measure surveys, seniors spend about 10 hours per day in a sedentary sort of mode. Boy, that in itself is a problem independent of the physical activity. And this interesting kind of population-based analysis that was conducted via the AARP in the States related levels of sedentary time, and denoted here as how many hours per day do you watch television, and separated it out into groupings of moderate to vigorous physical activity. And you can see, for instance, in this left-hand panel here, that the red bar are people who are active regularly. That is, they spend an hour a day working out. They're the best group, and they watch very little television. They're going to be our reference group for having the lowest cardiovascular mortality. But you could see that in every one of these bars, as the levels of vigorous physical activity go down, well, then the risk of cardiovascular risk of mortality goes up. But then also within each of these groupings, if you simply spend more of your time watching television, if you're a committed television watcher, if you're a binger, if you're a Netflix aficionado or whatever platform you like, you can actually double your cardiovascular risk, irrespective of how much physical activity you engage in on a daily basis. And that's true for the regular exercisers. It's even more true, of course, in terms of overall absolute risk, in terms of people who are inactive on a regular basis. So we might might say that, in geriatric comprehensive assessment, we're concerned about places like the kitchen and the bathrooms where we might fall down. The couch might actually be the most dangerous place or the setting in the home, at least in terms of cardiovascular risk. Prolonged sitting doubles our cardiovascular death rate, even in regular exercisers. So we need to move on then to some solutions. And there's been a lot of great sort of guidance, and undoubtedly this group is very familiar with this information. This was a nice a review that was published in the Applied Physiology, Nutrition, Metabolism Journal in Canada. This is kind of the home journal for the exercise groups in Canada, and the sort of the editorial from this guideline was that exercise is the medicine to reverse or mitigate frailty, preserve quality of life, and restore independent functioning in older adults at risk of frailty. So there's some good guidance in here and some good information that will inform the next few minutes of this chat. Oops. Before we move there, I just want to take a moment to talk about these names that we're using. I recall at a conference where I was presenting on this topic, I was chastised by members of the audience because I may have inadvertently emphasized the term exercise when I kind of meant it as a overall term for being active. They said, no, it makes a difference. And if you tell some people that they must exercise, they'll actually have antibodies against that term. And we need to use more inclusive language that might be something like physical activity. It might be something like movement, or it might be more specifically not being sedentary. And in my world, I think all of the activities are important. They're individualized in terms of what we might discuss or prescribe if we're doing this in a medical mode to the individual in front of us. So I hope you'll take this in the spirit that it's intended, that for some people, it might be programmed bodily exertion for a set period of time for the sake of developing, improving, or maintaining physical fitness. And we do this in cardiovascular rehab, I think, as the core construct. But in other of our clinics or day hospitals or residential care environments, we may be focusing on chair-based movement or not being sedentary as best we can, depending on the individual that we're working with. So it's all good, but I do agree that sometimes we should be very specific about the nomenclature that we use. So if we talk about exercise, because that is the term that was used in this particular guidance from a few years ago, it took us through recommendations on looking at the older adult in front of us, thinking about them as non-frail, pre-frail, or frail. And you are more familiar than I with the various sorts of tools that are available as kind of classification algorithms around frailty. For non-frail individuals, if we start there, the kind of the general guidance around physical activity for older adults can apply. So then the question is, well, what is that guidance? Well, the previous version of the Canadian Society for Exercise Physiology guideline laid it out nicely in terms of tabular format. I want to start there, and then I'll move into the updated guideline in just a second. For trainees who might be on the line, and if you ever had to answer a Royal College exam question about what is the physical activity recommendation for any population, how much aerobic exercise per week, then the answer for every single population is 150 minutes of moderate to vigorous intensity aerobic physical activity per week. Pointing out, of course, there's nothing magical about 150. If you did 149 minutes, that's good. If you did 152 minutes, that's good. If you did 30 minutes, that's good as well. But there's this kind of arbitrary threshold that's set for 150 minutes as a reasonable population guideline, recognizing, of course, if the population that we're working with is completely inactive, then doing 10 minutes is a good first goal. And that's a victory, and that actually starts to impact on the chronic disease trajectory. Most guidelines for older adults and younger adults, of course, will say we should do some resistance exercise as well. That's using bands, free weights, soup cans, water bottles, weight machines, whatever it might be. But doing muscle strengthening exercises and bone strengthening exercises is a great thing for cardiovascular health, for metabolic health, for overall health. And I think there's interesting exercise that the combination of aerobic and resistance is good for your brain as well. And we should think specifically about balance. And, this is the first kind of age stratum where balance becomes more emphasized. It probably should be everywhere, but it certainly is emphasized for the older adults. And the question of is more better, then sure, this denotes that there isn't a single threshold, it's a continuum. If you can do more, it's probably better. And it's interesting when we get into the next slides that when we think about frailty interventions, we probably should be doing more, but just thinking about the intensity of all of that, of all the activities that we are doing. The updated guidelines around physical activity for Canada now emphasize not just this sort of single threshold of 150 minutes, which was the easy answer, but thinking more of your whole day or a 24-hour movement guideline. And for adults over the age of 65, the 24 hours would include these major buckets of being physically active through the day. That includes that aerobic 150 muscle strengthening, balance, thinking about sleep as a significant third of your 24 hours, and thinking about sedentary time in an active way, I guess, that, trying to limit the amount of long duration screen time, breaking up sedentary time as much as possible. That's important for heart health. It's important for metabolic health. It helps control sugars much better, for instance, if you're living with diabetes. So think of this as a more comprehensive answer around what your healthy 24 hours should be for most individuals before they get to the states of pre-frailty or frailty. But if you get to those states, both pre-frail and frail older adults should still do all those things: aerobic, resistance, balance, flexibility. But let's think about how we might construct the day or the activities a little bit differently. And the guidance from a few years ago, I quite liked it because it actually gave a bit of a recipe in terms of like what the construct of an exercise program might look like. So if we contrast the pre-frail to frail, they each include those slices of the pie that include aerobic and resistance and balance and flexibility. The pre-frail will probably have more muscle strengthening and balance than aerobic activity. And the total amount of time is bigger than it is for the frail population. Once you're getting to more frail, then we're going to do aerobic activities a little bit more as that exercise session. And then the other ones will comprise about an equal weighting through them. So this allows for some customization according to the person in front of you. It says that we do need to defend muscles early on. And it's interesting how this sort of guidance can translate across into some of the disease populations we work with as well. I'll come back to this when I talk about cardiovascular populations in a couple minutes. But those are the ideas on how we might put this together. You'll see some of the fine print here denotes the frequency per week and the levels of intensity that we can derive for this. As a rule of thumb, if you're doing this at a moderate level, not too much, not too little, but just right, that's the thing that we need to do. For most people, you don't have to go to high levels of exertion and cause undue distress or symptoms from underlying conditions. Doing moderate levels of activities are quite effective in terms of preserving or actually gaining things like cardiovascular fitness back to that VO2 equation. So in detail, the pre-frail individuals should exercise 3 times a week for 45 to 60 minutes per session. That takes them out to the 150 minutes or more. Frail older adults should exercise 3 times a week, but for a slightly shorter duration. But of course, we can customize and you can do more or less depending on what else is on the plate for these individuals. And if you do a little bit more on a regular basis at the right intensity, that's a good idea. Also important to build in, though, some rest days so that we don't cause overuse injuries for some of our folks. Okay, let me see. Moderate intensity, as we said, you can actually categorize this on an exertion scale. This guy, Gunnar Borg, who's a Swedish physiologist, said you can look at activities on a light to very hard scale, stick somewhere in the middle, and you'll be okay. And resistance training should be incorporated. And if a particular patient client that we're working with actually has the opportunity to work with an exercise professional, then that professional will probably go through some sort of assessment of different kinds of exercises, like a bicep curl or a tricep extension, and figure out what the appropriate weight level might be. They might do something called the 1 rep max test of how much weight can you lift where it's still comfortable, and then back off a bit and take a percentage of that. And that, again, brings it to a moderate level of intensity, not too much, not too little, but just right. So if we do these sorts of things, does it make a difference? Because we said that, you know, the fitness kind of trajectory, the muscle trajectory will lead us over the edge of the cliff. Frailty becomes more common. Most of the population is inactive. It looks like a hopeless situation. But actually, if you do these sorts of structured exercise, physical activity, movement interventions, then it can make a difference. And, you know, low physical activity has been demonstrated to be one of the most common components of frailty. And if one looks at papers, that there are clearly improvements that can be gleaned in terms of reducing the risk and occurrence of falls, improving mobility, improving balance, improving functional ability, improving strength, improving body composition, and lowering our kind of scores of frailty as well. So this is something that indeed is modifiable, and we need to pay attention to this domain. In the cardiovascular realm, what happens in our shop? You know, the average age of people coming to our program is 64. So that says that we see 1,000 people that would fit in, at least that fit into the older age category. And this is the basic recipe that we will use to safely and improve fitness in a cardiovascular rehab type of program. And as a footnote, that this kind of program is available to your patients as well, if you see the need, if you want them to be enrolled into a structured lifestyle intervention program that can improve fitness and strength over a period of time. We will typically start with some sort of structured assessment, and the stress test is one of the components, along with kind of medical review, medications, psychosocial domains, dietary habits, other lifestyle factors. And from this, we can determine a safe and effective level of intensity for the exercise that can be conducted with aerobic training and resistance training and balance and flexibility. It's the recipe makes perfect sense. I will say that the cardiovascular world has been doing this for about 55 years. So this was one of the prototypes for safe and effective exercise programming for all kinds of populations, including seniors. It's relevant as another kind of use case in the cardiovascular arena. Like, these are data for people who live in Toronto, back to this kind of perhaps theoretical construct in the literature that fitness or VO2 might relate to things. Well, for people who actually live in Toronto and come to us with cardiovascular disease, fitness is an extremely important marker for long-term trajectories. And when we actually assess fitness levels using cardiopulmonary testing, you can see here in this analysis that Terry Kavanagh published a couple of decades ago in Circulation. This was a 25-year follow-up of people with heart disease in the program. This is total mortality on the y-axis. And if we separate by tertiles of fitness, that people with low fitness compared to high fitness, unfortunately, the low fitness group below that threshold of 15 mils per kilo per minute had the highest levels of death compared to people with better levels of fitness. So that was quite striking of the importance, again, of VO2 as a construct. And if we think about interventions, if we package everything together, like that physical activity construct, following those recipes for non-frail, pre-frail, and frail, that this is another real world analysis of people from our program. The y-axis is, again, overall survival, and the x-axis is a follow-up over 5 years. The pink line are people that actually do a structured rehabilitation program for people living with heart disease. The blue line are a propensity match cohort in Ontario that did not do rehabilitation. And the difference in death rate is 50%. So quite marked. This is not a randomized trial, of course, but is tantalizing to provide support to the notion that, you know, doing those exercise programs is a nice thing, and maybe even more than just a nice thing. Maybe it's a must thing, because no surprise to all of us that when you get older, you lose muscle mass, you lose fitness, that portends the bad things to happen. And this is one of those evidence pieces that we can do something about it in a more morbidity and mortality kind of construct. So I think that's really important. And what about the age cuts from this? We've analyzed the data and published it according to different age categories. And here we're just illustrating what happens in the 40-year-old decade, the 60-year-old age decade, and the 80-year-old age decade. And you can see here from an older kind of data system where we were systematically testing people at baseline, 6 months and 12 months in terms of their VO2. You can see for the young group, they start off just over 20 and they'll go up over 25. The 60-year-olds, they start off at a lower base, but they'll go up. And the 80-year-olds, of course, who are the interest for this particular conversation, they start off below our 15 mil per kilo threshold. They're around 13, which says bad things are going to happen very shortly, but we can push fitness up even for this category. And the relative increases in VO2 are rather similar regardless of your age category. We would, of course, argue that this, being the most vulnerable age category, really deserves these interventions in a very systematic way so they can actually improve. Okay. There's that threshold thing. So, you know, elsewhere in the cardiovascular realm, you see lots of people in heart failure with heart failure in the geriatric realm, and we do in our cardiovascular populations. If we dive into the physiology of what goes on in heart failure, this recent review in the Journal of the American College of Cardiology talked about the physiologic deficits that are present in people living with heart failure. And if we go around the boxes, you know, reduced pulmonary reserve, and then reduced cardiac reserve, and skeletal muscle dysfunction, and then other things like anemia or malnutrition or dysautonomia will all contribute. And if this was instead an article about exercise intolerance in seniors, I think you'd probably come up with very much the same list of issues. So heart failure actually is an interesting model for intervention from a physical activity perspective. This article further goes into, of course, therapeutic interventions, and there's a slew of medications and maybe devices that might go into people with heart failure. But of course, one of the unifying interventions that can address every one of these boxes and most of the abnormalities on the screen is, of course, physical activity and exercise as a core construct. In the setting of heart failure, there's been a series of randomized trials and a series, therefore, of updates in the Cochrane Library of overviews of clinical trials. And depending on how the endpoint is cut, you can see that there's either a positive trend or a positive outcome for important things like mortality and hospitalization related to heart failure and overall cardiovascular disease if you exercise on a regular basis. And you know, here I'm pointing to the effect size. I acknowledge that the confidence intervals may overlap one, but everything is consistently in the right direction for these things. So no surprise, we've got lots of recommendations for exercising well in the heart failure setting. And, once again, the parallels between aging and heart failure are very, very strong as we go through there. I'm kind of just one side thought about exercise models and how we might actually shake things up, even for populations who we might think are rather more vulnerable. This simplified line diagram denotes what we might think of as a standard exercise model on the y-axis with intensity, on the x-axis with time. So the red line says we'll do some sort of warm-up with gradually increasing intensity, plateau this out for 10 or 20 or 30 minutes at a time, and then take people down through a cool down period. And this would be standard kind of exercise recommendation. Walk on a treadmill, walk on a track, cycle on a bike, get into the pool, or things like that. So what's interesting in the cardiovascular world is that there are different approaches to exercise where we can take that sort of trapezoidal shape and then put in kind of indents up and down through this. And of course, you'll all recognize that this represents something called interval training. Some of you may be doing this in the gym today, where you're in a spin class, or you're doing some other kind of cardio if you're back in the gym, or if you're a runner and you're doing hill work or fartlek maneuvers from lamp pole to lamp pole kind of thing. The idea is that you warm up, have a basal level of activity, and then for short intervals, increase, recover, increase, recover, increase, recover. And I bring that up as a different model of exercising that can be quite effective when one looks at the outcomes from this kind of program in heart failure and the rest of other kinds of cardiovascular conditions, compared to moderate intensity continuous exercise, the so-called higher intensity or HIIT in interval training results in greater improvements in peak fitness levels, typically in a shorter period of time of training. Typically, people said they like it because it's just not as boring as walking on a treadmill for 30 minutes at the same speed. It's more cognitively engaging. The adherence levels might be better with this. And for folks with some compromise in their exercise abilities, the notion of going up in intensity and then recovering can actually be quite attractive, and it might be what they do naturally, which is quite interesting. So these sorts of models are being used more often, not only in heart failure but in CAD and atrial fibrillation. We might even bring them to a geriatric population as well. In the home stretch of this, just want to introduce a couple of other concepts that we're engaged in as well, that we can think of exercise interventions after cardiovascular things happen. But we can also think about exercise physical activity interventions before we get into trouble. And of course, the role for prehabilitation. This is a growing area of research. And this kind of overview from a couple of years ago that looked at people who were undergoing prehabilitation before major abdominal or cardiac surgery were shown that a structured prehab program that typically went for 2 to 3 months before operations, that included physical activity and nutrition and other surgical readiness, people that did the program experienced a lower rate of overall complications, pulmonary and cardiac complications as well. So there have been trials, maybe some of you have actually participated in them in this area. There are prehab programs that are being set up in the city. At UHN in particular has one for people undergoing various kinds of procedures related to cancer, other conditions. And for our world, we're launching a new project doing prehabilitation prior to transcatheter aortic valve implants. Of course, a very relevant population. Many of these folks are actually in a pre-frailty or frail state already. So getting them ready for a procedure like this is great. Because sometimes our interventional colleagues forget that fixing a valve does not fix, in quotation marks, the person, that actually doing a whole body kind of activity is going to be helpful. So do the prehab, do the procedure, and then do the proper rehab after time. In a recent Geriatrics Journal Club from last November, this article was introduced by one of your outstanding trainees. What I want to come back to on this was now I think we have a good appreciation for the intervention as it was delivered. This infographic from that paper, that was interestingly published in the New England, looked at about 350 people that were kind of randomized into a cardiac rehab type of program versus a control. And these folks were hospitalized for heart failure, had frailty or pre-frailty for most of them. And the program that was offered included aerobic and resistance and balance and mobility programs delivered over 12 weeks. And the short physical performance battery measures of physical functioning were clearly improved over a relatively short period of time of 3 months. So this makes good sense on another example of how the program can actually be implemented and make a difference for individuals. Okay, very much the home stretch here is that if you want to see a little bit more about what we're doing as a cardiovascular rehab program, most of our materials that we use with our patients is online at a site called the Health E University and the Cardiac College. Within that, we've got sections of the web as well as patient handouts and videos and activities that are in there around getting active in particular. And one can look through a actual video library of resistance training exercises, either using body weights, like how to get up off the floor, using light dumbbells, or using rubber elastic bands. So if one wants to just give some quick advice about, strengthening exercises twice a week is a really good idea, go to this website and look through it. And you can actually kind of walk through a playlist of safe and effective exercises that we use with our seniors who are living with heart disease. So this is kind of an evidence-based program because we can also show you that fitness and strength improve by using this kind of program as well. And if you wanted people to actually come to the program, then you can go to the website, go to the section called How to Get Referred, and you'll find referral forms to either one of our sites at Toronto Rehab, located at Bayview Eglinton, or at the Toronto Western site. We'd welcome your referrals to either. So at the end of this, I wish I could have seen you while we were going through this, but I hope that you've been there throughout. That here's what we've covered off: that seniors may have very high risk profiles and poor baseline fitness. This is a factor of aging. It's a factor of society. It's a factor of health behaviors. But what the data show from our shop, what the literature shows, that we can actually improve fitness significantly regardless of age. And this is really important because this is the modifiable risk factor that can be important for longevity, reduction in morbidity, and preserving independence. The constructs around movement that include exercise, physical activity, being active wherever you are, and not being sedentary are all important. Pick one to work on for the person in front of you. Cardiovascular rehabilitation is an available resource as one of the kind of exemplars of physical activity, exercise, movement, and kind of ideas for more collaborative programming would actually be quite interesting and welcome. One of my good collaborators in the U.S. is a geriatric cardiologist, and it's a delight to talk about program ideas with him. Okay, stopping there, going to stop the share.
Thank you so much, Paul, for a fantastic presentation. I can guarantee you that people were getting up out of their chairs and maybe squats in front of their computer monitor, motivated by the evidence that you were showing us. Nice. There are a few questions in the chat, and we'll start with Mercedes Orzito asks, has anyone looked at the effects of COVID restrictions on fitness, and has there been a bump up in mortality?
Yeah, so fitness, I don't know if fitness per se, like overall sampling of the population in terms of what their cardiovascular fitness levels might be, but certainly there are a number of population-based surveys that have been done that talked about how the population behaviors certainly changed. And again, you can divide it into threes, as all things in medicine, that there are some people, maybe like the group online, that might have actually taken advantage of not going to the office every day and actually being able to fit in a workout on a regular basis. There are those that were able to maintain, but certainly there's a large segment of the population that, because of isolation, because of restriction, because of loss of access, became much more less active, and risk profiles would have the associated risk profiles got worse. Mental health got worse, physical health got worse as a result of all of that as well. So there is a recovery that certainly needs to happen. I can't speak to mortality specifically in this age group, but I think we're all interested. That'd be an interesting thing to dissect, of what's actually causing bumps. Is it COVID? Is it chronic disease? But none of it is good, I would imagine. So I agree completely with you, Marissa.
Thanks, Paul. And Dr. Gandel asked a tough question. Is there an intersection between neuroscience and the molecules being investigated for senescence and a link to improved fitness? Dov, do you want to expand on that? Do you want to unmute?
Thanks very much. Great talk. I was just wondering if some of these molecules, aside from improvement in senescent cells, maybe in animal models or so, improve VO2. A lot of the antioxidants, the polyphenols and flavonoids, and fisetin is one that was presented to our group recently. I wonder if there's any thought on that.
So I don't think I'm smart enough, frankly, Dov, to answer the question. I love the idea, though, and I'm looking for intersections in my world that certainly shared pathways of things like oxidative damage that's common in cardiovascular disease. It's common in many chronic conditions. It's common in cognitive impairment with aging. Common in mood disorders, and how we might be able to modify those kind of insults to our system through physical activity. I think that's been shown, so that we can overall improve the system, perhaps mitigate some of the impacts of the kind of the toxic environment. Using pharmacologic interventions to mitigate some of this stuff as well. You know, we're actually involved with some nice collaborative research with our colleagues in neuropharmacology that looks at the role of antioxidant therapies and other ways of modifying insults to the heart and to the brain in terms of preserving cardiovascular function, improving cognition, probably improving overall cardiovascular health as well. Pharmacologic interventions to improve fitness are interesting. Changing muscle physiology with a pill, I'm not quite sure about that, but there are interesting interventions where functional capacity might be modified through kind of changing either cardiac function or muscle function. So there may be ways of modifying the fitness equation through that. Of course, we always say when we have that pharmacologic interface or device interface discussion that it's always better if you do both, right? And my facetious thing that I'll say as a pharmacologist, but also to chide my interventional cardiology friends, is that all the medicines are good, but they're actually much better if you take them out for a walk first. And this may be true for kind of novel, interesting kind of interventions that may be coming down the road.
Thanks,
that's
Paul.
probably a terrible answer to that very elegant question, but that's the best that I'm going to do.
It was a tough question. Thanks, Paul. And Gary Nagley wants to ask about recommending walking for our patients, and does that meet the requirement for moderate physical activity?
Yeah, so thanks, Gary, and hi, Gary. Walking is definitely kind of one of the major activities that we do recommend. Why? Because it's accessible to everybody. All you need is a decent pair of shoes, and away you go. So absolutely walking, but just thinking of the intensity, which I think gets to here, that we can walk slowly or we can walk very, very briskly. And in fact, you get a very good workout for doing so. Walking at a moderate pace is probably the most common exercise that we recommend in our cardiovascular rehab programs. We would target the intensity, the pace of the walk to heart rate targets that would get people into the right zone. But absolutely that walking is a core thing that many people can do, and it works extremely well and would be an evidence-based intervention for sure. Thanks, Gary.
And Thero has a question about measuring cardiovascular fitness. So I think, is there a practical way to measure VO2 outside of the lab?
Yeah, so interesting, because we were just having this discussion with some research projects that we're into. And there are ways to estimate VO2 in the office setting. There are questionnaires that one can sort of guesstimate. If you think of something like a Duke Activity Status Index, which is like a dozen questions about things that you can do versus not do. Can you shop? Can you cook? Can you clean? Can you vacuum? Can you go upstairs? And that gives you an estimation, understandably, of how fit you might be. The correlation actually with real fitness is imperfect. Office-based, you can do things with a couple of steps. They can estimate your VO2, and there's equations and algorithms to do that. The devices that people have, smartwatches, for instance, are not bad in terms of their VO2 estimation. The caveat being for older people that might have low levels of fitness, some of those algorithms may not be as good as they might be. But hopefully they'll be improving over time as broader range of population is getting them. So, I, like many of you, might be wearing an Apple Watch, and there is a VO2 estimator that's in there. And I'm going to declare that I have this conflict that I disclosed at the beginning, but the science behind there is actually pretty good. They've got a lot of exercise labs and some very smart PhDs that are behind those algorithms. So that's why I'm bringing them up, and there's a white paper about that. So there are ways to assess this in addition to doing cardiopulmonary testing.
Well, thanks so much, Paul, for giving us the evidence to support the advice that we're giving, as well as practical tips on how to instruct our patients to increase their activity. I think the bottom line is that any amount of increase in activity is good, that the lines separate right away. So just increasing a small amount is a step in the right direction. And I think we should all take that to heart and increase our own physical activity as well. The slides will be shared along with the evaluation link, and the recording will be made available on our website. And I want to thank Dr. O again for joining us today for the Citywide Grand Rounds. Our next Grand Rounds will be taking place in May 5th. And Dr. Murray Norris will be presenting on her role as the Department of Medicine leader for Black and Indigenous students. A very important topic, and I hope you can all join us then. Thanks very much, everyone. Have a great day.
Thanks. Good to see you.
Thanks, Paul.
Okay, bye-bye.